So you got the lab results back. Potassium is 6.4. You gave the standard treatment, it dropped to 5.1. But next morning, it's back at 6.3. Now the real problem isn't your management. It's about figuring out why the body cannot get rid of potassium. In the next few minutes, I'm going to show you 5 questions that you ask whenever you see a high potassium, and you'll never miss another case of hyperkalemia. So the first question you need to ask is this potassium even real? What I mean is, you see the report, but your patient is fine, his ECG is fine, he has no obvious cause for his potassium to be high. You're probably looking at a pseudohyperkalemia. This is what happens when potassium leaks out of cells after you draw the sample. You see the sample that you send to the labs contains serum, but also blood cells. When there are more cells or more delay in processing, the cells rupture, releasing a lot of potassium in the serum. This can occur because of hemolysis during blood draw, traumatic venipuncture, or simply because there are more number of WBCs or platelets. So when you see high potassium with normal ECG and no apparent cause, just repeat potassium. And maybe don't use torticate this time. So first question in hyperkalemia is this real? That makes a first step. So you repeat, potassium is still high. Good, you're actually dealing with a high potassium now. Next thing you need to know is if the kidneys are okay. Why do they matter anyway? See, the kidney is made up of millions of nephrons, and in the collecting duct of these nephrons is where the magic happens. As you see, the ENaC channels on the principal cells of these collecting ducts, they take in sodium. So that leaves the tubular fluid with a negative charge because sodium, a positive ion, has left the tubules. This negative tubular fluid then causes potassium to leak out of the principal cells by the ROMK channels. So in a way, kidneys are trying to conserve sodium, but potassium gets eliminated as a result. But why this weird design? To understand this, let's go back in time. I promise this will give you a new insight into the renal physiology. See, early human diet consisted of mostly vegetables and very less amount of salt. So we had surplus of potassium and very limited sodium. So we evolved to conserve sodium and get rid of extra potassium. And kidneys smartly evolved to unify both of these processes and make them more efficient by using ENaC channels. If this is the apical membrane, sodium enters the principal cells, and since the lumen then becomes negative, the cells get rid of potassium. This potassium is washed away by the flow of urine. So to excrete potassium, a number of things need to be functioning right. Think of it as a machine. You need the ignition key to start the machine, the switch. Then you need fuel for it to function. And you need the machine to be flushed regularly for it to function smooth. Now the key here is actually the key hormone aldosterone. The fuel is sodium that is exchanged with potassium. And flushing is done by the flowing urine as it washes away the potassium, leaving room for more potassium to exit the cell. These are the 3 main pillars, and if even one of them fails, the whole system fails. So when you have a normal kidney, you need to be concerned about 2 things. The first, remember we talked about sodium-potassium pump in the previous video. If you haven't seen that video, check it out now. These sodium-potassium pumps are present on cell membrane of most cells, and they function to keep the potassium inside against their concentration gradient. But if these pumps fail, or cells are lysed, the potassium leaks out of the cells. And why do this happen? A number of causes actually. Acidosis, beta blockers, insulin deficiency, digoxin toxicity, severe hyperglycemia, exercise, and rhabdomyolysis. Hyperglycemia actually causes more intracellular dehydration, which results in a much higher concentration of potassium in cells, making it even harder for the pump to keep potassium inside the cells. So the third question you ask is there any evidence of shift of potassium? Another problem that can happen with a normal GFR is problem with the ignition key of the machinery. That means that your whole machinery is not switched on. That means a problem with either the hormone aldosterone or the epithelial sodium channel, or ENaC in short. Aldosterone problems include low renin, primary adrenal insufficiency, or drugs like RAS blockade, while the ENaC channel can be inhibited by drugs such as Amiloride, triamtrene, and even Trimethoprim, and sometimes because of inherent channel defects in ENaC, which we call as pseudohypoaldosteronism. So that makes the fourth question, is this a hormone or a channel problem? Now, if there's evidence of reduced GFR like high urea creatinine or even low urine output in acute settings, the cause changes. Remember the machine analogy. We dealt with the starting key just now. Now what happens with reduced renal function is there are simply fewer machine units to excrete potassium. So the fewer machines are overloaded now. There is simply lesser sodium reaching the distal nephron, so less potassium can be exchanged in view of that. Also, when there is low urine output, the potassium that does get excreted in the tubules doesn't immediately wash away, so further potassium can't be excreted. So last question becomes, is this a kidney problem? In this way, we can figure out why the potassium is high. You need to answer these 5 questions and you're good to go. And in most patients, you wouldn't even need all 5 of these. So that's it. Use this approach with sight and you'll never miss a single cause for hypotassium. For more videos on electrolytes, follow my channel and watch the playlist on electrolytes. And if you have any questions regarding electrolytes, drop them down in the comments. What's the next topic you want me to do a video on? Let me know. See you in the next video. Till then, like, share and subscribe to Renal Dose.